Good morning, everyone. The topic for today's UG clinic is hypertensive retinopathy. So, what is hypertensive retinopathy? It refers to the changes in fundus occurring in a patient of systemic hypertension. It is always bilaterally symmetrical, and it is also a microvascular pathology like diabetic retinopathy. That is, it affects the very small vessels rather than the larger vessels. It is caused by systemic hypertension. Either the systemic hypertension can be acute or chronic, or there can be a rise of either the systolic or the diastolic blood pressure, and it is usually taken as a sign of end organ disease manifestation. So, there was a study conducted to know the incidence or prevalence of hypertensive retinopathy known as the Beaver Dam Eye Study, which evaluated hypertensive patients without coexisting vascular diseases. The incidence of hypertensive retinopathy was about 15% in them. Specifically, 8% showed retinopathy and 13% showed arteriolar narrowing. So, what is hypertensive retinopathy? It refers to the changes in fundus occurring in a patient of systemic hypertension. It is always bilaterally symmetrical, and this is also a microvascular pathology like diabetic retinopathy. That is, it will affect the very small capillaries and vessels, but not the larger ones. It is caused by systemic hypertension, which can be acute or chronic in onset, and it can be caused either due to increase in the systolic blood pressure or the diastolic blood pressure, and it is usually an end organ disease manifestation. So, there was a study conducted known as the Beaver Dam Eye Study to learn the incidence of hypertensive retinopathy amongst hypertensives. So, in the Beaver Dam Eye Study, which evaluated hypertensive patients without coexisting other vascular diseases, the incidence of hypertensive retinopathy overall was found to be 15%, and specifically 8% showed retinopathy. Etiology or risk factors. Now, hypertensive retinopathy is the second most common retinal vascular disease after diabetic retinopathy. It is associated with systemic hypertension and malignant hypertension. So, systemic hypertension is when the blood pressure is greater than 160 by 90 millimeter of mercury, and it is called malignant hypertension when the blood pressure is more than 240 by 140 millimeter of mercury. So, the first risk factor is race, in which Afro Caribbeans are twice at a risk as compared to other races. Then gender, males are more commonly affected as compared to females, and then age also. Then genetic or family history, obesity, smoking and alcohol consumption, which increases the incidence of atherosclerosis, stress, and lack of exercise, or basically sedentary lifestyle. Pathogenesis of hypertensive retinopathy occurs in three phases. First is the vasoconstrictive phase, which includes diffuse arteriolar narrowing, focal arteriolar narrowing, and reduction of artery to venule ratio. Then exudative phase contains flame-shaped hemorrhages, cotton wool spots, and hard exudates. And lastly, sclerotic stage includes sclerosis of the vessel wall in the form of copper wiring and silver wiring, and AV crossing changes. These I will discuss in the further slides. Now, the Keith-Wagner classification of hypertensive retinopathy. This is the most important thing which you should remember and which will be asked in your examination. So, this classification was formed by Keith and colleagues way back in the year 1939, and it has four gradings. So, the first grade or grade 1 is mild generalized retinal arteriolar narrowing. So, hypertensive retinopathy is a pathology more commonly affecting the arteries than the veins, whereas diabetic retinopathy is a pathology which affects the veins more than the arteries. So, in the first grade, there occurs only arteriolar narrowing due to sclerotic changes. So, the normal arteriovenous thickness ratio is 2 is to 3. So, in hypertensive retinopathy, this ratio changes into 1 is to 3. Now, grade 2 is focal arteriolar narrowing and arteriovenous crossing or AV crossing changes. So, in the first picture, you can see that there is a focal narrowing of the artery. That is, in its origin, the artery is normal in its diameter, but then as it progresses ahead, there is a thinning. Now, AV crossing changes I will discuss in the next slide. Then the second change is copper or silver wiring, opacified appearance of arteriolar walls. So what is copper wiring? When the light reflects from the vessel walls takes on a reddish brown kind of hue due to increase in the atherosclerosis, then it gives the appearance of a copper wire and hence the name copper wiring. And when this atherosclerosis progresses and becomes more severe, then there is no blood inside the vessels, and the whole of the light falling on the vessel is reflected back, giving the appearance of a silver wire. So the AV crossing signs which are very important to appreciate. First is the Salus sign, which is right angle deflection of retinal vein as it crosses the arteriole. Second is the Bonnet sign, where there is banking of retinal vein distal to the AV crossing. And Gun sign, where there is tapering of retinal vein on either side of the AV crossing. So why AV crossing changes occur? It is it occurs when the sclerotic artery presses upon the vein, and this AV crossing changes always occur at the junction of the artery and the vein. So the first picture shows the Gun sign and right angle crossing, that is the Salus sign, and the second picture shows the Bonnet sign where there is distal banking of blood. Grade 3 of Keith Wagner's classification is grade 2 along with retinal hemorrhages, which can be in the form of dot, blot, or flame shaped hemorrhages. Now, flame shaped hemorrhages are more common in hypertensive retinopathy. These are superficial hemorrhages which are present in the retinal nerve fiber layer. Dot and blot hemorrhages may be present, but they are more specific for diabetic retinopathy and they are deeper hemorrhages and hence they are smaller in size. Then cotton wool spots or soft exudates. These are basically areas of focal ischemic infarct of the retinal nerve fiber layer as a result of exoplasmic flow disruption. They are present in the retinal nerve fiber layer and hence they are larger in size, appear as cotton wool balls, and have fuzzy margins. Then hard exudates are lipid or lipoprotein laden macrophages. They are present in deeper layers and hence they are smaller as compared to the soft exudates or cotton wool spots and are waxy in color and have well defined margins. Now, hard exudates again are more specific for diabetic retinopathy. In hypertensive retinopathy, they are indicators of chronic renal edema and appear usually in a peculiar pattern which is around the fovea, which is known as the macular star or macular fan, as seen in the fundus picture given. Now, grade 4 of Keith Wagner's classification is grade 3 plus optic disc swelling. As you can see in the fundus picture given, the margins of the optic disc cannot be appreciated, and there are a lot of hemorrhages on the disc surrounding the disc, which are known as sphincter hemorrhages. So, this is the picture of classic optic disc swelling. Usually in hypertension, the optic disc swelling will be bilateral and it is known as papilledema. So grade 4 is grade 3 changes plus papilledema, and this is a marker of malignant hypertension. Now, hypertensive retinopathy can also involve the choroid, and if there is involvement of the choroid, it is known as hypertensive choroidopathy. And in hypertensive choroidopathy, you are supposed to see two signs, which is the Elshing spot and Segrè streaks. So, what are Elshing spots? These are focal choroidal infarcts seen as black spots surrounded by yellow halos, as seen in the fundus picture given. Then Segrè streaks are flecks arranged linearly along the choroidal vessels, which are indicative of fibrinoid necrosis basically. So you will not be asked details about hypertensive choroidopathy. You should just remember the names Elshing spot and Segrè streaks. Lastly, the management of hypertensive retinopathy. It is not as extensive as diabetic retinopathy. The main aim or the main treatment protocol for hypertensive retinopathy is lowering the patient's blood pressure level with antihypertensive drugs. This is your questionnaire for hypertensive retinopathy. Thank you.